speaker today is Alexia. We'll be talking about childhood academic performance. Does low birth weight for gestational age influence school performance? And so Alexia Searchfield is a second-year PhD student in health sciences at the University of Auckland. Her passion is biostatistics, and she finds data, especially big data, very exciting. She uses statistical models to identify risk factors for adverse health and well-being in infancy and childhood. Her two main areas of interest are sudden infant death in infancy and small for gestational age status. Alexia's PhD uses a combination of data from the Auckland Birthweight Collaborative study and integrated data infrastructure to form a holistic view of the effect of term small for gestational age status in education.
So we are going to take a step back from the IDI for a little bit, but I promise we will revisit it towards the end. And that's just because I only just got into the IDI. So I would be standing here with a blank presentation, I think, if it was just about that. But yes, ko Alexia tōku ingoa. Thank you for all being here today. As it was very nicely introduced, I am looking at childhood academic performance, specifically for infants that are born with a low birth weight for their gestational age. So before we get started, just a very brief introduction to my research team. Obviously, Barry Milne seems to be a common theme of today, but yes, so co-supervised by Barry and by John Thompson, who is over in medical and health sciences. So for a bit of background, what is small for gestational age? So it might be a term that is not very common for a lot of you, but essentially it's when an infant has a birth weight in the lowest 10th percentile on a birth weight standard. And this adjusts for sex, gestational age parity, which is the number of babies the mother has had, including the current birth, ethnicity, and maternal height and weight. Now, some, but not all of these infants are going to be what we call fetal growth restricted. Now, these terms are very often confused, but essentially small for gestational age is composed of two groups. The fetal growth restricted group, which is essentially the infant on the right, and that infant exhibits characteristics of malnutrition. And then constitutionally small infants, which are the majority of small for gestational age, and they're genetically predisposed to small stature. Now, discriminating between the two groups is very challenging. Fetal growth restriction is the target group because they experience more adverse health outcomes. However, clinicians will generally use SGA as it's a comparatively simple to obtain. And this is what a standard birth weight standard will look like. This is for a boy, but essentially all those below the 10th percentile here, based on their gestational age, will be considered small for gestational age. So what was I basing my research off of? Well, a number of studies have demonstrated that small for gestational age babies experience a variety of adverse health outcomes. So development of diabetes and renal disease, but cardiovascular disease is another one. And we don't quite know why this is, but we suspect it's due to a combination of placental insufficiency, which is malnutrition in utero, and either slow or rapid catch-up growth. So once the baby's born, do they achieve normal birth weight? Fast, slow, not at all. And we also know that placental insufficiency can result in the underdevelopment of the brain. And so we'd like to understand if this brain stunting can manifest as low educational performance in later childhood and into adulthood. So how did we define our educational outcomes? Well, we were basing this off of what the Auckland Birthweight Collaborative, which was a study I'll introduce you to a little bit later. But essentially, we were able to obtain progressive assessment tests, or PATs, which some of you will have done in oral comprehension, written comprehension, and mathematics. And this is part of routine standardized school testing. So this isn't just for our participants, this is for everyone who's at school. And we were given their results on an achievement scale, which we converted to stay nines. And at 11 years, they were assessed using either the PATs or assessment for teaching and learning, which are the EASTLs, which came into effect around the same age the study was being conducted. And it just depended on what school they attended, which made our life a little bit more challenging. And they also use a separate scale. So we actually had to approximate stay nines, which obviously introduces a little bit of error, but we were able to account for a lot of that. And for those of you who are not familiar with the stay nine distribution, mean of 5, standard deviation of 2. And for our purposes, we essentially said these are the students achieving below average, and then everyone else was just essentially not achieving below average. So I said I would introduce you to the ABC. Well, it was a cohort study based on a case control design. It's from 1995 to 97, and these were infants born in the Auckland healthcare region. But it also included some from Waitemata, but it just depended on the time of recruitment. We ended up with about 1,700 infants, and these were followed up at 12 months, 3.5 years, 7, 11, and 16 years. But for the purposes of this, we're just focusing on 7 and 11 years. I will note, and these are 2 big points when it comes to the IDI. So we were not able to look at outcomes for non-Europeans, and that was because we had such poor follow-up past 3.5 years that they decided not to collect data at further points. And this was what we call an exclusively term population, which meant that we weren't including babies born prior to 37 weeks completed gestation. And so, yes, so once we excluded all of the non-Europeans, we ended up with a baseline cohort of 871. As we are all very aware, we lose quite a few with time. And so by 7 years, we had about 569 that had education data. And at 11 years, we had 436. So our results. At 7 years of age, we found that small children are 1.75 times more likely to achieve below average in written comprehension, but that once we adjusted for confounding, that effect was no longer significant. So that's here. And then at 11 years of age, we found that small for gestational age infants are 2.2 times more likely to achieve below average in oral comprehension. And when we adjusted for confounding, we did find that this effect remained significant, but the effect size shrunk quite a bit. So I said we've adjusted for confounders. We found that males are at a higher risk than females for achieving below average, just in general. Children with younger mothers are at a higher risk of achieving below average. Children with fathers that attended university are at a lower risk compared to children that fathers didn't attend university. And children from middle socioeconomic areas are at a greater risk. But I will note that due to our demographic, we had a highly affluent population. So that's something we want to address later on. Which brings us to the IDI. What happens if we include infants that are premature? What happens if we are able to look at different ethnicities? And can we address issues with a small sample size? So obviously I've only just started getting into the IDI, so there's not a huge amount to say here. Just based on who I'm talking to, I assume we all know what the IDI is. But for our purpose, it contains birth information and educational outcomes for infants born between 1998 and 2005. And we decided on that time frame because that includes all infants who would now be at university or that age. So we have a bigger scope. But also, if we go prior to 1998, we end up with no gestational age and no birth weight, which means we can't calculate our birth weight centiles. And our outcome, well, we're looking at essentially the same outcomes we did for the ABC, but we wanted to use big data to explore some, to be able to obtain more accurate estimates. Specifically, is this effect present for preterm SGA? And what happens if we aren't using an exclusively term ABC data? Now, our educational outcomes, primary and intermediate school, the achievement is predominantly teacher reported. And so it just introduces some issues with subjectivity, and the results aren't particularly comprehensive. So we are going to focus on educational attainment in high school and tertiary education. And we're using achievement level and course, but mainly achievement level. So if those who aren't aware, essentially achievement is on a 10-point scale The first three are what we essentially think of as being our level 1 and through 3 at high school. 4 and 5 and 6 are a combination of high school qualifications through to pre-university, and then bachelor's through to doctoral degree. Is now, mind you, we're probably not going to have a huge amount in doctoral because they're about my age at the time of follow-up now. Yeah, so who knows? We'll see what we find out. But thank you all for listening.
Much wider range of areas.
Yeah, I think so. The nice thing about the ABC is that since it was set up to be a study looking at outcomes, they ask very comprehensive questions. So we're not going to have such, so we're going to struggle to find such in-depth questions, but we will be able to adjust for a variety of different things. But also sample size is going to help so much because we had to, our confounders, even just categorizing, we had to kind of restrict the number of categories we had. So yeah, no, I'm really looking forward to that.
You might want to just talk to Eileen about the percentile score. That's it basically is a measure of how well they did at school at a particular level, 2 or 3 or 1 if you do, that adjusts for the difficulty of the achievements they took.
Okay.
Essentially.
Okay. Yeah, we'll have to
if
do
you're
that.
taking really easy ones and pass everything, you don't get as high a score.
Oh, well, that's nice to know because I know that that's an issue at NZEA. Okay, cool. Brilliant.
Now there is one in the chat.
Oh, cool. Should I just read it out loud?
If I understood correctly, your outcome is poor educational achievement. But what if SGA children had lower average achievement than non-SGA children, even if it wasn't poor?
So I guess, yeah, we define poor academic achievement as just achievement below average. And I essentially, the goal is if we know that small infants tend to not achieve at average or above average at school, we would be able to implement, whether it's reader writer, like you might have ADHD or other like dyslexia, but it's just providing them with more support. So you're right. So yeah, so we kind of encompass, so essentially it was just in our definition that poor educational achievement essentially meant below average educational achievement. I probably should have made that a little bit more clear, but yeah, hope that answers your question.
But the point is also, once you go to the IDI, and you can look right across the distribution.
Oh my God.
Because you didn't have much scope for looking across scales.
No, absolutely. I think it's gonna make my life a lot easier once I'm in the IDI in a lot of ways, which is scary to think. Yeah, 100%. So no, that'll be another thing. That's it. Yeah. Yeah.
One more in the chat. Since most SGA is not due to growth restriction, how worried should parents with SGA babies be about their educational achievement?
Well, from this study, not at all, because it looks like, at least if your baby's born at term, that SGA doesn't have a huge effect on education. But you're right. So there are a number of techniques out there to try and work out how to separate constitutionally small from fetal growth restriction. But often they require a mum to present with one or more risk factors for them to then go through the process of getting serial ultrasounds to then determine that there's something going on with growth. But if essentially, since it's only about 30% of those born SGA and that we find that SGA isn't a risk factor for poor education, we're probably okay. But you can often tell once they're born if they've have characteristics of malnutrition, and then those ones will get targeted care versus those that are just born looking very normal but very small. And you can definitely tell from how they look at birth.